place a regular OMED shunt inferotemporally. And the idea was to place it in the sulcus with a partial thickness patch graft. So recently they have stopped considering patch grafts necessarily. They now allowed us to start using patch grafts again. And so a lot of us have developed different ways to tunnel the tube through the sclera into different locations. I find it that it's hard for me to do that when I want to put it in the sulcus. And so I did a partial thickness patch graft. So I just dissected 50% of the sclera so that I could use his host sclera and reduce the risk of having any kind of elevation for his contact lens. I went to go do a full-size on it. I just couldn't get it in there because his inferior orbital rim was just too tight. So I used a pediatric one, which is much smaller. Post-operatively, he was 14 on both sides on Cosopt and Alphagan. He ended up having his vitrectomy. He had his ERM removed, and his pressure went up to 32, and so we added oral medications. This is not a great picture. I try to do the best I can, but you can kind of see the tube sitting there, right anterior to that fibrosed capsule. And, you know, this was earlier in the post-operative period because you can still see his vitreal sutures haven't dissolved. But he healed really nicely from this without any contour issues. And I did the same thing on the other side. And you can kind of see, I don't know why this picture looks like it was taken in the 60s, but you can kind of see that nub of the tube there. So the position was good. The contour of the sclera was good. Pressure was okay. So he had his lecture travel schedule. His pressure went up, so I decided to do a micropulse laser. So we have the diode laser. We have two versions, the G probe, and now we have the new micropulse, which is meant to gently reduce pressure, has thought to be safe to be used earlier in glaucoma, can even be considered to be used in phakic patients. I think this laser maybe came out, I think now 4 years ago. And so we've had some good experience with it, and I'll tell you kind of what I think is ideal for this laser. But he settled to about 20 without oral medications. He developed a PCO, so I did a YAG, and his pressure went back up despite the oral medications. So micropulse, I just wanted to take these photos, and this is not him, but I just did this laser earlier today. And the main reason I want to take the photo is because the goal of the micropulse, and I'm sorry this photo's small, is to try to get the laser to reduce the production of fluid from the ciliary processes. The probes that they have been designed to automatically be at that distance based on setting them at the limbus, and then the location of that probe should shine right onto those ciliary processes. However, as we all know, everybody has variable anatomy. So what I do is I transilluminate and I mark off the anterior to where the pigmented portion starts. And the idea of doing it anterior is you don't want your laser anywhere in that space. So there's just two different images where I do that. And the interesting with that marking of it is you definitely don't want to go over the ink because that absorbs some pigment. So the idea is to stay away from that. So the micropulse laser, some of the things I've learned is you have to have that right position. So earlier in the adoption of the micropulse, there was a lot of placement too anterior, and a lot of patients had permanent mydriasis without pressure responses. And I think we've learned to move it further back a little bit. And the recommendation from the company is about 10 seconds per pass. It's usually about a 90-second treatment per hemisphere. But I think you have to go even slower. So I do about 30 seconds. You have to maintain continuous contact, almost like writing with a pencil. You have to have a viscous interface, and you avoid 3 and 9 still. I think there's always, in my experience, has been a 30% failure rate where I don't get what I want. And the one thing I would stress about this one is that the Iridex does not mention hypotony as a risk, but if you do it right, you can make it work. And so hypotony is a real concern on some of these things, some of these lasers, because if you hit the ciliary process perfectly, you're moving slow enough, you have that perfect contact and interface, I've created hypotony. So we have to be aware of that risk factor. So we just reviewed our data, 187 in the last few years, 18 months follow-up. We get a 9-point reduction, 1.2 med reduction. And I think this is the most important part, the severe diagnosis for over 90% of our patients. And so the laser has been used as a primary treatment. And I just think that's a little early because I'm a proponent of working on outflow as opposed to reducing inflow, primarily because you can never turn the pipes back on, but you can always take out a pipe or something. So I think it has to be skewed toward the more non-surgical candidate or the severe diagnosis. So we completed it. The optimal settings we found in our studies, which is what I now use, is 2,000 milliwatts and then 135-second application per half, which is, it's set to 90 seconds, so it's 1.5. You avoid 3 to 9 in any areas of scleral thinning. I completed on both sides. He got to 18 on all his medications. He had a steroid response and he was back on oral. So then he developed allergies to medications. And now we're here. So I just saw him maybe day before yesterday. And on oral pills, I didn't update this. He had taken acetazolamide 125 in the morning only, and he was at 9. So we've stopped it, and I get to see him tomorrow to see what I'm stuck with. But the question is, I have no further medical options really for him. So my options are to monitor him at this level with serial visual fields. Based on his prior history, I haven't really gotten any better besides taking the cataract out. And his vision's gotten better. He can tolerate the scleral lenses. But I haven't necessarily stabilized his pressure unless we all believe that the tube shunt really reduces fluctuations, which is enough. I've seen the optic nerve change. So we've seen change over time. There's been damage happening as it's been working. So the question is do you do an endocyclophotocoagulation or a repeat diode? Would you do an additional shunt, maybe non-valved? Would you consider a Zen device or some sort of filtration, but I can't really needle it? I can maybe suture lice, but I can't really get to the blood too well. I wish we had a suprachoroidal indication, like a CyPass that was removed for a pseudofake, but we don't. But maybe there's something off-label I could consider. So that's where I'm at. I've got a patient where I don't know what to do, and I'm going to turn it to Dr. Smith and Dr. Tosin Smith and Dr. Vest to tell me what to do. Dr. Smith, I'm sorry why I did that slide that way. That was not correct. It's Dr. Smith and Dr. Vest. Sorry.
Hey, no, that's fine. Hey, I want to congratulate you on your perseverance. This is one of those glaucoma patients where, like you said, they've had every surgery in the book, whether it's corneal surgery or glaucoma surgery, so to speak. And sometimes we have patients like this that create a challenge. I had a similar patient of uveitis that was sent to me by a referring doctor that actually got a CyPass before the CyPass was taken off the market, and a whole bunch of surgeries as well. And we're finally coming to a place where pressure is controlled after going through a series of things. I think if I had to look at this patient and first of all, deciding where we need to be, I'm sure we'll all agree that we probably need pressure somewhere in the mid to low teens, preferably here. We would be trying to find a situation where we're on fewer medicines as much as possible, trying to get that patient off oral medication actively. The discussion of contact lens wear or not is a big issue, and it might be important enough to the patient, but we might have to sit and have a different type conversation about the possibilities here. The situation where the patient has a really, sunken orbit restricts certain procedures that I would recommend at this point. So I have a couple of questions. And my first question is in doing a trabecular bypass or stripping or sort of dilating procedure, did you strip or you just dilated viscodilation?
So in him, I stripped 180. Sorry, I forgot to mention that. And I'll tell you, for some reason, I've had trouble with uveitis when I've stripped too much. I don't know you have done much more GATs than I have, so you would have more experience there. But for that reason, I stripped 180 and not the full amount.
Well, the secret to doing the GATs and in patients who have uveitis is that the uveitis has to be controlled. They can't have any inflammation. If not, you essentially end up back where they've zipped shut this trabecular meshwork you've opened. And we apart from the steroid response in uveitis, we also know that trabecular meshwork is kind of clogged with the uveitis cells. So where would I go next with this patient? The next question is, was the vitrectomy complete or not?
So the vitrectomy was complete per the retinal surgeon to allow me to put a shunt in the back if I needed to. In the
Okay.
proximal.
So those are good things. Because this patient has uveitis, I'll be a little wary about going back to do any kind of cyclodestructive procedure. I know we consider micropulse. The micropulse laser is thought to do a little bit of, depending on what energy level, do a little bit of that cycloablation, but there's also some belief that it helps to improve trabecular outflow as well, just based on the mechanics of the laser. But if primary pathology here is somewhere in the TM, then we probably, in this particular patient, I would take the option of moving to a non-valved implant. We've tried an Ahmed. I know it's kind of hard to get in there. I may go with a 250, either a 250 Barvelt or ClearPath type implant. So it's a much smaller size. It's much easier to slide into place. Just judging from the number of medications the patient is on, at least for a while, I'm hoping we won't end up with a hypotenuse situation where if he stops making aqueous. So that would probably be where I would go. Now, the discussion then comes as to if it's critical to the patient about needing to wear the contact lens, then the consideration of putting that implant in the back posterior to the IOL so that you leave room, even though I know there are some specialty contact lenses that can create a little notch over the area where the tube goes in the eye, but you can consider putting that in the backside of the eye, since this patient has had a vitrectomy as well. That would sort of be my next place to go. Regarding the Zan, and it's going to be hard to needle, like you said. That orbit is really tight. You need somewhere for the fluid to flow. I wouldn't revert to a trab at this point as well. So I would be that person who opts for a non-valved implant. We can start with a 250. So you leave yourself some other quadrants of either a Barvelt or a ClearPath. Zach, what do you think?
I think if Shamil can send patients to Warren Hill, I'm going to keep in mind that I'm going to tell patients they should drive down to Arizona and see Shamil. This guy came into my clinic. So just quick, for those that are not familiar with some of these, so that ABIC that Dr. Patel is talking about, again, is going to dilate Schlemm's canal, and you can use that same catheter to cause a trabeculotomy, which is a nice, the other kind of disposable is an Omni, which is very similar if any of you have patients that have had that. But I agree. I think I would lean towards non-valve tube in the pars plana. I'll tell you that contact lens wear is brutal for us, but it is so vital for patients. I think especially now with scleral lenses, you know, patients aren't just coming in their RGPs anymore. And I think a lot of those patients, I mean, if they're post-PKP, they have bad ocular surface disease. If they get out of that scleral, they just cannot see worth anything. And they will, even if you control their glaucoma, he's going to hate you for life. So I think the pars plana should give you enough room, I think, to still fit any type of contact lens that would be necessary. So I think that would work out well. I'll say the one thing that I do tell patients in this situation is I often will tell them that I'm going to do a canthotomy for them in the OR. So I'll tell them, hey, you're going to wake up and you're going to have a little split. You're going to have sutures right here, just to try to get just any extra space you can, especially if you're going supratemporally. Sometimes that will give you just a little bit more, so at least you can see where that implant is going. Of course, I did that for one 80-something-year-old patient that was on, you know, blood thinners and aspirin, and didn't stop it like we talked about, and just, you know, then your whole surgical field is just blood. So that does come with caveats, but I think that's one thing that I think maybe I could add to the discussion is I think there's nothing wrong with trying to get yourself a little bit more room.
The other thing that I would just add in there is that I remember this particular patient actually also came to me with an Ahmed implant, and I actually did a trade-off. I took the Ahmed out and I put a non-valved implant out of that quadrant because she already had 2 implants in there. And by the time, you know, I didn't fenestrate, so gave it time to heal nicely, and that really helped us to lower her pressure as well. So if you need an option later on, that also is a thought.
Would you ever put an anti-metabolite in a tube?
With tube shunt surgery, we know the anti-metabolites don't work, so I would not. I would not in this particular question. The other thing that I would consider is I don't know how their uveitis is doing in itself, whether what they're on. You know, it might be the type of patient who needs to get off of steroids and needs to move on to other type of you know, immune modulating type medication to control their glaucoma, to control their uveitis.
Thank you. I have my, I will report back to him tomorrow because he'll be seeing me. And I told him that I was going to get expert advice. So thank you very much.
Oh, you're welcome.
Well, at least you got advice from one expert. That's the important thing. All right. So man, so I'm just going to have some layups now compared to Shamil's case. That was, that's a tough one for sure. Let's see. So again, if you guys have questions, don't hesitate to shoot them over to Dr. Hovland is our Q&A guru for today. So if you need to shoot him something, please feel free to shoot him a message. You can also message him privately if you would like. All right. Okay. Here we go. All right. Okay. Okay. Everyone see that all right? Okay. All right. So we're going to go through the case initially, and then we are going to talk about blood revisions just in brief for folks. So this is a 34-year-old gentleman who was referred over to me, congenital glaucoma. He actually has a really neat story. His mom actually brought him to the U.S. as a kid because in their original native country, the doctors there told her that there was nothing they could do for him and he was going to be blind. And so just be prepared to have a blind son. And she actually, I'm not sure how, found that there were glaucoma specialists in Denver that would take care of pediatrics, since they're, you know, obviously that could be found anywhere, just about in any major city in the U.S. But she found a glaucoma doc here in Denver and came here to Denver specifically to see this doc who's now since retired. He got a couple angle-based surgeries. Sadly, one of his eyes was already NLP. It eventually became painful and it was enucleated. But he has one eye, had 2 angle-based surgeries when he was younger. Eventually, when he was 18, he got trabeculectomy. And it worked well, so much so that he disappeared to follow-up to seeing anybody for multiple years, goes in to see a general ophthalmologist because he needs new glasses, and he has a pressure of 44. He has no bleb. He's put on max meds, gets to 35, and gets referred over to our clinic. And of course, he looks like the classic patient that has elevated congenital glaucoma. He's got an extremely large corneal diameter. He has a very, very deep anterior chamber and a very long axial length. He wears -19 glasses. And so just a very large eye. So the question is, in this gentleman, what are we going to do next for him? We have, and I'm actually, we'll actually let everyone put in their hat and throw in their 2 cents. Our options are, we can either do a fresh trabeculectomy for him. He's on max meds. He's also on oral medications. So he is maxed out. He's 35, his only eye. So we can do another trabeculectomy for him. We can do a tube shunt. We can revise his trabeculectomy, or we can go to something new, which would be a gel stent. Obviously, we have micropulse as an option, but I think as Dr. Patel discussed, I also don't do that in young folks anymore. Initially, it was discussed as a nice, gentle option. And then I did it on a younger person. And shortly thereafter, there was discussion on the AGS network about the Glaucoma Society network about it causing loss of accommodation in young patients. So that came out about a week after I did my 30-year-old patient who was not happy with that. All right, so let's take a look here. All right, so we have a good number that are saying they would go ahead and proceed with a tube shunt. We know the TVT study, the trab versus tube study, did show that a large non-valved implant does well in people who've had prior trabeculectomies. And so what do we consider in these patients? And we'll come back to these results here in just a second. It looks like that was about 40% of folks were voting for a tube shunt. So trabeculectomy revisions. This is something that was first described back in 1941, first reference I could find, just using a needle to help open up a prior glaucoma surgery. Once we got to the 90s, we started having use of antimetabolites, 5-FU, mitomycin C, to try to augment the success of these needling procedures or these augmentations. And there are multiple ways that you can revise a prior bleb. Most commonly, we think about a transconjunctival approach. This is just going to be, this can be done at the slit lamp. This can be done with in the OR. And essentially all you're doing is sliding a needle underneath the conjunctiva, breaking up as much fibrosis as possible, trying to find the scleral flap and lift it. Now, one of the elements to this is trying to identify where the resistance is. And this is, I think, one of the things that I've really come to appreciate much more out of training is essentially that's the big question when you're looking at blebs is where is the resistance? What is making the pressure go up? Is it conjunctiva or is it the scleral flap? And we'll look at that. Or is it potentially something blocking it internally? There's the option of a transcorneal revision, and we'll look at that here in a little bit. And that's, I think, heard about that from some folks down at Bascom Palmer. Dr. Palmberg kind of has discussed that as a technique. Dr. Smith's group has discussed the ab interno revision, and this is the picture down here is actually a picture of a Grover spatula. It's essentially a specially designed spatula to allow you to go ab interno. So as opposed to using a needle and going out through the conjunctiva, which is what you normally do with the needling, this device is going through the clear cornea, across the anterior chamber, and through the ostomy. So it is going through the hole that you punch, and then it comes out underneath the scleral flap and allows you to break up that fibrosis that's both underneath the flap and around the bleb. And then you can have an open revision. That's this picture here, which is one individual's drawing in their paper of their technique, where they essentially made a fresh scleral flap, but you can open up the conjunctiva multiple ways to essentially reestablish flow. Now, why would you do this? Why not just go to something else? And essentially, this has a quicker recovery time. It can be done in the OR or in the office. So that is a benefit to surgeons where we're having less and less OR time availability, trying to maintain clinic flow. And it's easier for patients, right? High cost of copays, deductibles, keeping them out of the OR is a nice option. The big one in my mind is that it saves conjunctiva for future surgeries. As we saw with Dr. Patel's discussion, conjunctiva is precious. One lecture I heard was basically called conjunctiva sacred, like you just cannot waste it. There's only so much real estate in an eye for you to use. And so we don't want to be kind of flippant or go too quickly to something else. Another benefit of revision is you don't have to worry about an implant. There's no worrying about erosion, breakdown. Is the implant going to fail down the road? And then you get the benefit that we normally expect with a trabeculectomy: low pressures, low medication burden. And then it has a reasonable chance of success. The other consideration in this gentleman is he's 35. This is not going to be the only glaucoma surgery he needs. And you have to think, is a tube shunt going to last this guy another 30 years? And the answer is no. Will a trabeculectomy last him 30 years? Well, maybe. It lasted him 17 years already. And actually, I tracked down the glaucoma doc who did the surgery, and it was before mitomycin C. So this was someone whose surgery lasted 17 years without any anti-metabolites. The other thing that was nice to talk with that doc about was to essentially kind of give him a pat on the back and say, hey, you essentially saved this guy's vision. And I think it's just a nice emphasis that all these things we're doing is really vital. Here's a gentleman who now has a job. He is living on his own. He's totally independent. And not that you couldn't do those things if you were blind in both eyes, but I think it is very much a different visual experience for him and a very different life for him and for his mom in terms of what he provided for him. And so that's just fantastic. Now, revisions can be successful. It's difficult to look at the papers that describe them. They're usually case reports, case series, and there are lots of different techniques, as we already discussed. And everyone kind of has their own secret sauce as to how they like to do these revisions. But ultimately, the answer is you can have good success, especially with mitomycin C. This is a pretty strict qualification for success. Pressure of 5 to 16, no glaucoma medicines, no further procedures. And they had 71% success at a year, 61% at 2 years. In my mind, if that keeps, 6 out of 10 patients needing a tube, that's a good number in my book for sure. Now, as we discussed, the status of the bleb is super important, and how you treat that bleb is going to be important as well. So this is an example of a encapsulated bleb. This patient's pressure is he's on max meds. His pressure is in the low 20s. He's refusing other surgeries, but you can tell his point of resistance is this wall of fibrosis around his bleb. That is really his problem. It's not anything with the flap. This is a patient who has a very ischemic bleb. This is a patient who you're going to be a little nervous about extra antifibrotics in because they already have this thin translucent flap. And so that's a patient that maybe you want to think about how you revise that. And then patients can have totally flat blebs. And the conjunctiva over it can be nice and mobile as if they've never had surgery before. And that patient usually is going to do, in my opinion, quite well with a revision. So why wouldn't you revise? Well, we have the same risks, but these are the same risks we have with any glaucoma surgery. That picture is a patient of mine where you can sadly see his retina right behind the IOL. That would be from a choroidal detachment. And then the other concern, and always in the back of our minds, is the potential for lost time in an uncontrolled patient. It is how much do you want to try to poke and prod this eye in clinic before you take them back to the OR and potentially do something more definitive. But again, definitive is a little bit in the eye of the beholder, and ultimately, how successful is it? So let's look at this gentleman and what we did for him. And now I'm going to say we're going to show this through my video. If people have problems with the video, I can share a link to the YouTube channel that has these. So if you notice that you're having a problem, just shoot it out in the chat function and let me know that the video is causing problems. Okay. Let's go ahead and get started. So this is going to be if everyone can see that, this is going to be a transconjunctival or transcorneal needling. Now, this was pretty early on for me. I probably would not milk the conjunctiva with a needle like this currently, but essentially what I'm looking for is trying to identify that scleral flap. And if you look right there, it's just there at the anterior edge of the needle. You see that dark line? That's where that needle line is, okay? And so what we're going to try to do here is we're going to take this needle, we're going to go through the cornea, and we're going to try to bring it out underneath that scleral flap. The other thing you'll notice is this conjunctiva is nicely mobile. It's not extremely scarred. And so our thought of success is pretty high. And so you can just see we're just lining up the angle that we're going to go at. You can also see this gentleman's eye is quite large. You can see that large corneal diameter. And so we're just going to go straight through the cornea here and find that scleral flap. And you'll notice a nice elevation of the bleb afterwards. Now, this does feel a little strange, I would say, to just kind of stick a needle through a cornea in this manner, but you'll see our results for this gentleman worked out quite well. Now, Shamil, Dr. Smith, how do you, when you all do revisions, what is kind of your primary technique, or do you necessarily adjust it based on kind of how the eye looks?
My technique actually depends on how the eye looks. So there are some things that I will needle in the office, and there are some things that I will prefer to take to the operating room. Generally, as a rule, if I have somebody who has a tenon cyst where you can easily at the slit lamp have them look down and do that, break the capsule and make sure we actually use that Grover speculum, the Grover spatula in the office as well, where you can break the wall and you have sort of, there's already connection. Then in the office, but in the OR, sometimes I would needle externally, but most of the time it's either internal when I take the patient to the operating room. And it's usually because you have that flap that's scarred down, or you have a situation where there is some scarring of conjunctiva as well, or there is a bleb there that's just not so functional. And I'm just trying to get a broader area and inject some mitomycin.
Mm-hmm. Yep. And so this gentleman, one of the reasons I went, you could ask, why do we do a transcorneal on this gentleman? In his case, one of the things that comes along with being a congenital glaucoma patient is that, again, that kind of ophthalmos, he's just got this large eye. He'd also never had any surgery that was not under general. Again, his last eye surgery was when he was 17. He's always been under general. So I wasn't excited about doing it in clinic. So this is in the OR. The other is that I was a little concerned with just straight subconj needling, because I couldn't see that flap as well as I'd really like. And with that really thin sclera, I was a little concerned about the potential of perforating the sclera from the outside and kind of creating some false tracks. I thought this way kind of provided a little bit better confirmation. And for those watching the video, you can see that just nice enlargement of that bleb afterwards. And we'll check here with a little bit of fluorescein stain, and that needle track doesn't leak. We also did give him some mitomycin C, so we did get some antifibrotics. So that worked out well for him. We have subsequently had to needle him a second time, but we did it in the same manner, and he's done well. Shamil, what are your thoughts about how you revise?
You know, Zach and Dr. Smith, this is I actually don't do the internal approach much, but that looks awesome. And so, you know, one question I have is, how do you be sure that you're at the ostomy? Do you do some kind of gonio identification, or do you mark them preoperatively to be sure you're going right through that ostomy to get to the flap, to make sure you're not making a new not a false passage, but a new passage? Because that gauge needle looks pretty tight. So you could probably get through almost anything with that.
Yeah.
That's really neat, though.
Yeah. So I'd say for this kind of transcorneal needling, I think you really are just trying to get that needle out at the level of the flap. I think that's really what you're shooting for. And so, yes, whether or not it really is following the correct contour or not, I think is a little less important, because you are assuming that you are hopefully going to come out somewhere underneath the flap, and that's what you're going to really reopen. So I do, before him, we did gonio, make sure the ostomy was patent, that there was nothing really blocking it. We did kind of look for those things. So, but I think from the ab interna with the Grover spatula, I do mark ahead of time, and you do have to do intra-op gonio to find it. And sometimes, I don't know about Dr. Smith, she has any tips, but there have been times where I can't just anatomically, if it's too superior or too superotemporal, I can't get that spatula in. And then I do, this gentleman's was very superotemporal. And so that was the ab interno approach. I was a little concerned about being able to reach it at such a steep angle.
Okay. I agree here. Just taking gonioscopically a view of the angle and knowing exactly what the anatomy is very helpful. You can make sure you position your paratrack kind of opposite where that is. It requires a little, gymnastics, so to say, acrobatics at the slit lamp, but you even if it's supratemporal, if you go infranasal or more infranasal and you work your way through there, you can at least get the flap up. The only other thing I will add is doing the ab interna also gives you that opportunity to leave some viscoelastic in the eye at the end of the case. So the anterior chamber is sort of formed, and I tend to leave high molecular weight viscoelastic, let some of that go under the flap into the subconjunctival area, and I leave quite an amount. And so when they come the first week, they're usually fine. Blurriness doesn't start until the second week, where they actually have to start making their own aqueous to keep the flow going. And hopefully inflammation is less at that point, and they're starting to make more aqueous. So that's the only thing I will add to that.
I'll tell you, that's one of the things I was also nervous about this gentleman is, I think we probably all needled folks in that eye. You get the right tissue plane, you get the right spot, that eye can get super soft real quick. And if you're just sitting at the slit lamp, you think, all right, I'm going to put this shield on. You do nothing but walk to your car and go home and sit in a chair and don't do anything the rest of the day, because it can get pretty soft if you get the right spot. So that's the other reason I agree with Dr. Smith. Sometimes it's nice to leave a little viscoelastic in the eye. The OR leaves you that flexibility to say, hey, this person's shallowing. And we'll actually see that here on the next case. All right, so is my slides back up? Did I switch it over? Okay. All right, so this is our next case. This is a 48-year-old female with a really interesting family history. This is one of those times where I wish I knew a little bit more about genetics or had more connection to people that had interest in genetics, because her daughter has congenital glaucoma and has had angle surgery, trabs in both eyes. Her mom has low tension glaucoma, and she got diagnosed with early onset glaucoma in her late 30s. And so there's this spectrum of just optic neuropathy in this family that's kind of interesting. Their one unifying factor is they're all high myopes. So she is medication intolerant, and that's because she had a really bad side effect to one medication, and has basically said, I'm never taking anything ever again. She's had this discussion with multiple glaucoma surgeons, and it was understandably one of the worst side effects I've heard, essentially a life-threatening side effect. So she's like, I'm not taking any eye drops. I don't care if they're different medication classes. We've talked about the physiology. We've talked about the mechanics. She's done with them. And so she got a trab 3 years earlier with a different doc, got needled once. She has a goal in the low teens with very severe visual field damage in both eyes. She's essentially cupped out in both eyes. One eye is already count fingers. Her good eye is 20/40. And so she came to see me. Her pressure's 24. This is 3 years out. We did a needling in clinic. There's no change in a month. So now we need to do something else. And so this is going to be our same question. Let's see. We will go to stop sharing that. We'll go to our next poll question. This will be the same question for everybody. This is a patient who has now had an in-office needling. They need a low pressure without medications. And they are, again, kind of a younger patient. What are we going to do for this patient? And this is actually their 20/40 eye. This is their better seeing eye is the other factor.
Zach, do you only see monocular glaucoma patients? That's tough, man. That's quite a niche.
You know, now that you say that, I had 3 in clinic today. So yes, more than I would like. More than I would like. All right, so let's see. So we got a good number of votes there. Let's stop and let's take a look here. Again, people love a good tube shunt. Trabeculectomy, a repeat trab is on there. Bleb revision, I must not be doing a great job selling bleb revisions for folks. They are just not winning. So I think the keys in this mind patient for me, well, let me ask Dr. Patel and Dr. Smith, what do they think about this patient? What are their thoughts in how they would address this patient? We'll see who wants to take a step back first. I think that's I'll call it Shamil. Shamil, what do you want to do?
You know, I always, in a young patient who's monocular, I always feel like I have to think of their overall lifetime of glaucoma. And so if I think I have an option or I'm able to revise or use that prior trabeculectomy, I'd like to. But it would really depend on the characteristics of that bleb. So if it has something that's amenable to needling, I would lean towards, or revision, I would lean towards that option. But if it's not amenable to needling, we'd have to think of another option. I think having the option of a filtration, though, such as a functioning trabeculectomy, is very important. In somebody as young as her with a strong family history, you can always augment with the tube, but she'll probably need both functioning to some degree throughout her lifespan. I'd lean towards revision to start off, depending on how it looks.
Mm-hmm.
So in this particular patient, I would actually go with a GAT. I will go with the GAT because she's 48 years old. A trabeculectomy from the time it was done, survived for 3 years. So she has that potential to be able to scar this thing down. She probably didn't have an option for angle surgery, which may mean, I might be able to revive Schlemm's canal and outflow if I do a 360-degree stripping procedure in her. She's young enough that, and if her glaucoma and high pressures are not sufficiently, haven't sufficiently sort of killed off or completely caused atrophy in the collector channels, I might be able to get that kind of effect in her age group at this point, rather than deferring that for later on. So this is somebody that I might go for a GAT and see what I get in terms of IOP control. And I have patients who have low pressures on a GAT, so it's a gamble. And that trabeculectomy will be there when I need it to revise it in a couple of years down the road. She might be older, and that at that point, her propensity to scar may be less further down the road. Maybe if it gives me another 6, 7, 8 years before I have to consider that. So that it's a little bit of just looking at the patient and looking at her history and just trying to see what might be the best thing. So that's what I might do at this point.
I may be sold. Now, I'm not sending patients to Arizona anymore. I'm sending them to Dallas.
No, I'm sending them to Dallas too. Forget it.
Let's expand that referral network. So actually, those points are all excellent. I did elect to revise this patient. We didn't talk about angle-based surgery all that much. Partially, I do like the GAT quite a bit. So I do GAT. For those that are in the audience, GAT is a gonioscopic assisted transluminal trabeculotomy. So essentially you're going inside the eye like you do an iStent or a Cahook dual blade, if you've seen those videos. Essentially, you're incising TM and threading some form of catheter, whether it's the old canaloplasty catheter or a proline suture, and running it around Schlemm's canal 360 degrees. You grab both ends of it and you basically pull it out, and it rips out Schlemm or trabecular meshwork 360 degrees, creates a very nice otomy. And so it is an excellent procedure. Again, even though it is also kind of generated at Dr. Smith's office with the Glaucoma Associates of Texas. And so I think a good backup option. So in her case, I did not. I revised her. We went to the OR. Again, for the reasons that Dr. Patel discussed, that essentially we need something for long-term IOP control. I thought the bleb was amenable, and we'll look at, we needled it a little differently than I did in clinic. I thought in the OR it could be a little bit more aggressive. You know, aggressive always sounds a little rough sometimes when you talk about glaucoma, but I think in this case, she just fibrosed down so quickly. It really was an attempt to try to just get this working better. So we'll pull up our video here again. And this is our next one. And we will do some talking while we're going along here. So this is, if everyone can see that okay. So this is back to Shamil's question about the bleb. So what we'd like to look at, we're just rolling a Q-tip here again. I learned my lesson from the prior surgery. I'm going to use something nice and blunt rather than a needle to compress that bleb. And what you can see in this patient is we have essentially almost a couple areas. Here is the original bleb is more kind of towards the top of your screen, and it has a ring of fibrosis behind it. And then the needling bleb, what I'm presuming is a result of the subsequent needling, is kind of what's closer to the inferior part of the screen, and that's a little bit more avascular, where she likely got repeat mitomycin C exposure. And so this one, instead of using a needle, we're going to go in with an MVR blade. So this is basically a super sharp blade. And the other point, what I wanted to point out with this Q-tip is what you'll notice is as soon as the Q-tip goes by, that bleb reforms just right at the tip. You can see the fluid flow in underneath the flap. If we do that again, you'll see the bleb immediately enlarge. And so what that tells me is there is fluid going through the scleral flap. So our fibrosis issue is around this bleb and inside the bleb, not really at the scleral flap. So we're going to go in and really excise the wall of this flap. We're going to lift the flap a little bit. That's what we're doing right there. But really, we're going to excise this fibrotic wall along the back. And that's what you just really can't do very successfully with a needle. It's just not going to give you enough resistance. So this is really, we're just going to essentially cut out everything we can with this blade. And just for the sake of time, we're going to jump ahead. I did go on the other side and try to get a little bit of this wall of fibrosis enlarged also. And the question is in this case, do you put any antifibrotics in? And this is always a little bit question. You're worried about flow back into the anterior chamber. Do you inject ahead of time or after? And I oftentimes will inject after the fact. And that is because I think it at least allows me to think about where do I want this mitomycin C to go and how much. And I think during the needling, you can get a little bit of that tactile feedback. So this area, again, the inferior bleb, which is now full of blood from the needling, is super avascular. I want to try to keep the mitomycin away from there because that's a potential area for breakdown, erosion. And again, our wall of fibrosis was around where my forceps are and where that needle tip is going. So that's essentially, I'm going to inject the mito right into that fibrosis and try to keep it away from these avascular areas. And so that's where our mito, we're just going to deposit it right there. And she has done well to this point. Now to Dr. Smith's point, we did sew these up so that they don't leak afterwards. We're going to jump ahead here. we did test and make sure that her anterior chamber was stable. So we watched her for a little bit. We filled her up with BSS, kind of pressurized the eye here. So we're going to pressurize the eye here with BSS. Raise it. You can see the pupil enlarged. So the pressure is getting up to probably about 20, 30 there. And we're just going to sit and watch it. Now, this is something that in the OR you have the luxury of doing. You can watch and make sure essentially that this chamber is not spontaneously shallowing. But then you can sit here and wait and double check and see, hey, is that pressure going down? So 10, 15 seconds, we're going to touch it, and it's just nice and soft. It's not that kind of hard pressure where we artificially elevated it, and it's not shallowing. So I feel good leaving this eye and going on, okay? So that's what we did for this one. I think now, after looking at the discussion, I'm going to, if her pressure goes back up and this fails, I'm going to GAT this patient. That will be her next step. Now, we are pretty much close to time. We had one more case to discuss. We're going to pause that. That was a tube revision in a patient. So we won't have time to address that. We'll maybe table that for another time. We are going to jump ahead then, and this is our contact information for everybody. As I mentioned, Dr. Patel, Dr. Smith, they're two of my kind of go-to patients. They're on my speed dial for complex cases. They're also people I reach out to for just kind of the practical aspects, work-life balance, you know, workflow, how to handle a practice. They're both in private practice. So I, you know, really appreciate their opinions because they put a lot of time and thought into lots of the same things I think about, what I worry about, what I wake up in the middle of the night thinking about. And so they're just, I know they'd be happy to be references for other folks as well if you feel like that would be beneficial for you. I think I need to share that information here. It would probably be helpful. And so that is their contact information. Please feel free. I'll put that back up in just a second, but please feel free to reach out to them. This is our credit claiming information. The QRS code is for any MDs, any ophthalmologists in the audience. If you just want to scan that, that will claim your CME credit for you. You can also go ahead and, if you don't have a QRS reader, you can text the information over. You do need to do this within 24 hours or else the code expires and I have to do some legwork for you. But if you have any problems with that, just shoot me an email. My contact, again, is up at the top. For our OD colleagues joining us, down at the bottom there is Kendall Johnson's contact information. She's who some of you received an invitation from. She's our point person for the obtaining COPE credit. And so reach out to her. We do have, when you registered, if you supplied your OE tracker number, we should be able to apply for that credit for you. If you have any questions, concerns about it being submitted, please email Kendall. Earlier this summer, there was kind of a backlog getting COPE credit approved and it getting through the process. So if it doesn't show up in your tracker, just give us a little bit of time, but that's the contact information. We'll also, so if you need to hop out, if you need to go watch the football game, you're welcome to at this stage, but we'll also open it up to some conversation, some questions, if anybody has them about any of these cases or about glaucoma in general. Complex folks you have, we're certainly happy to use them if you have any of those questions.
Just as a comment to your last patient, Zach, I know this is a lady who you said, you know, was not open to the use of any drops at all. And a lot of us thought like a tube might be a good option for her. In considering that, we should remember that in the tube versus trabeculectomy study, that the tube group of people tended to need more medicines to get their pressures to those sort of goals. So which is some of the reasons why I would either opt back to revising her trabeculectomy or try an angle-based procedure, because we know tube shunts work for glaucoma later on or even earlier on, as we see with the primary tube versus trabeculectomy, but we may need to be on more medicines. So I like your choice for this lady.
I would agree with that. And I think that's one of the other components, and a good point that Dr. Smith is bringing out is when we think about glaucoma surgery for folks, it isn't just about getting the pressure lower. It's about what do we expect this surgery to actually achieve. I think sometimes we think about surgery almost like another medicine, like as you mentioned, the GAT procedure or the micropulse. Okay, your pressure's 18, I want you to be 12. Let me just add something else on. But all of these surgeries have a physiologic mechanism. They are going to get patients to a relative range. And so it isn't just like adding on more medicines to try to get the pressure lower. They are going to have floors and ceilings about where they can get folks to. And as you mentioned, tubes, they can potentially, I think we all probably have tube patients that are on no meds and are on 10 to 12. But that's not the norm. I tell my tube patients, you're going to still need medicines most likely, or potentially some diode or something like that to help supplement them. So I agree. I think that's an important consideration. That patient that is medication intolerant, low pressure goal, they still are benefiting from a filter. I think the other thing that I think about is not just pressure goals, but then what is oftentimes we kind of move away from trabs. I think that's the other thing is with all of our new stuff, we're always wanting to try other things. And I think it's really good for patients to have these options, but some patients ultimately still need a trab. That's still what's going to be the best for them. As painful as it is for me to say, that is, I think every time I sign up a patient for a trab, I really am reminding myself, this is the best thing for the patient. I really don't have other options, or I'm really doing them a disservice doing something else. Shamil mentioned, I think earlier, about getting the pressure lower for the long term. You know, you think about some of these patients, I could easily slip a Ahmed valve in this patient, our last case, but we know that she's likely going to be at least back on meds by 6 weeks or by week or by 1 month. And by a couple of years, she may not have a functioning tube. And so that's just really doing her a disservice at that stage if that's what we throw into her eye. So post-op long-term really is important management.
I think one of the neat things we have in the glaucoma world now is we can chip away at the disease. You know, before you had to swing for the fences, and if you missed bad. You know, so even 9 years ago when I started in Phoenix, I was doing trabs, G-probe diodes, tubes, and external canaloplasty, and just started doing eye stents with comfort. But the eye stents never did enough for the real disease. And now, I mean, you just think of the armamentarium we have, and, you know, I tell patients my mentality with glaucoma has changed. Like, I don't mind doing 3 or 4 surgeries on you if they're all very low risk. But that's one of the cool things that's happening with glaucoma, especially, I'm sure, Dr. Smith, you know, you all are at the cutting edge of the research, so you have access to some of the stuff that we haven't even seen, which is making it even safer and safer to intervene even in the office. I'm sure, you know, like with the stents that can elute medications and Illumigan SR or the Durista, all those things you've had experience with, and those are super safe ways to take away the medication burden, which, you know, in my mind, medication is effective for lowering the pressure, but, you know, it's a chemical compound. It's not natural. It's a poison to some degree. We're using it for its effect, but there's always a side effect. So if we can figure out a way to take away that burden with safer options delivered directly to the tissues, I mean, we've got so many options now to be able to treat glaucoma. We can really customize it to each person.
It's, you know, it really is. I always say it's a great time to be a glaucoma specialist. And if I compare now to when I first started this journey 20 years ago, where the options were, we were excited just to see latanoprost show up on the market. And it's just so exciting to be a glaucoma specialist now. And even for the surgeries that we've done that we know are the true, tried, and reliable, like trabeculectomies, you know, I have a particular patient who had a trabeculectomy who had worked for 7 to 10 years that one of my partners had done way before he retired. And I got there, and just when I started the practice, I needled that bleb in the office. That bleb worked for 9 years. And she returned 9 years after. I needled that bleb again. and it's doing well right now. And so from her trabeculectomy, she's gotten close to 30 years from her initial surgery. And so it's all these, we're learning just how to either keep the things that we've done alive, or options that breach that gap between medication or, you know, mild to moderate glaucoma, or moderate disease, instead of jumping all the way to the trabeculectomy. There are all these options, and that just that's so refreshing. It's a good thing for our patients because we're providing better care, and we have all these options that, because people are living longer too, that will carry them through the whole their whole entire life, keeping them seen, which is ultimately our goal.
Yeah, I'd agree with all those things. I think there's at least once a day, every time I'm in the OR, that I think this would be horrible to be trying to trap this patient. And I just think back to people that were glaucoma specialists 30 years ago, when you trapped everybody or you did a diode. I would think there are a lot of these cases that, I mean, would just be horrendous, whether it is NVG or silicone oil or prior buckles or all these really tough cases that we now have other tools and other options, or even just the patient that's, you know, medication intolerant. They have mild disease. That the tradition, you know, the book answer, even when I was in fellowship, was surgery when medications are either don't work or the patient's intolerant. And so, you know, you would offer a trab to a patient who, you know, maybe couldn't take eye drops or do something else, even if they had mild disease. And here they're taking on all this risk, you know, of lifetime risk of a big surgery. And now you have other things that you can offer them. It's beforehand. And I agree with Dr. Patel, this idea of, hey, I'm not going to do something to save you for potentially 20 years. I'm going to do something that's going to hopefully last you 2 to 5 years. And we'll see what new technology we have, what new surgeries we have, what other cool stuff Dr. Smith's group has come up with that's going to, you know, let me do something also less invasive for you. So it does work out well, I think. And I think it is a good time for glaucoma in general. All right. Okay. Looks like our question box is pretty clear. I think it looks like Dr. Smith did answer Dr. Sid's one question. I think I am, we have a lot of patients. I'm at share office with a cornea specialist, so we have a lot of patients in sclerals. So I see a lot of patients with sclerals. You know, you definitely see that blanched conj. You definitely see a nice impression in the conjunctiva when that patient takes her scleral off. So I think as long as they don't have hardware in that area, either a filter, a Zen, or a tube, that I think as sclerals are a fine option. I won't be concerned about them using it. The main thing is drop compliance, making sure they put the drops in before they put the scleral in, and give themselves enough time, because again, they're putting in a giant fluid-filled lens onto their eye. I think that's going to rinse out any AM medications before they put it in. So I think that'd be my only thoughts about sclerals, is really emphasizing how they use their drops and making sure there's enough space before they put their scleral in. All right. Well, we will start to close it down then for folks. Certainly, again, if anyone wants to hang around for a little bit, we'll still be chatting. But again, if you need credit, please email Kendall Johnson, or please scan the list. And we will otherwise kind of let everyone sign out for the day. Thanks, everybody, for coming. And again, thanks to Dr. Patel and Dr. Smith for donating their time. Greatly appreciate their advice and recommendations on these patients.
Thanks for having us, Zach. A lot of fun. Good to have us.
No problem. Once you do it once, you're on the short list.
Dr. Tosin, Dr. Smith, I've actually, a lot of our optometrists in the community, we've talked about the scleral lenses in angle-based surgery. I don't think it makes a huge difference.
Not really.
Do you think it doesn't, right?
No. I think the you know, episcleral vessels are deep enough where it
deeper.
Yes. So I don't think that would affect it. So that will be fine. It's mostly in the presence of a bleb and a vascular bleb. And sometimes, it depends on just how much indentation. You may have it compressing your flap. Ultimately, over time, very slowly, you hinder or hamper the flow of aqueous into your bleb. You know how sometimes you put a contact lens on a patient for a time, which is why we do it, because we have a bleb that's sort of super functional. And then you kind of reduce that aqueous flow to the bleb. So I would just, stay away from it with a trabeculectomy, especially if it's tight enough where it compresses.
And I think especially, unfortunately, I had one patient with keratoconus who had a tube shunt placed by me, and then I lost him to follow-up, and then I saw him next for endophthalmitis off of an erosion over the tube shunt.
Oh.
And so, I think that's one thing I need to do better is either discuss it with the patients to make sure they're not allowed to do that without discussing it with me. Because in his case, I wasn't part of his referral network. Okay. So with the referral network, I can discuss it with my referring doctors, but that taught me a lesson that I really need to talk to the patients and make sure they never go into lenses without talking to me.
Yeah. And I always have my patients, once they get surgery and refit, they come back and we have them put in the lens. Same thing. I tell them, you can make sure the fit works, but I want you to come back with the lens on and don't wear it for extended periods before I look at it. Another cornea doc in town referred me a patient, said, hey, I had this patient with a tube. It eroded. I fixed it. It eroded again. I fixed it a second time. It eroded again. Could you look at it? And of course, she's wearing a scleral lens, right? And so so we, measured her out, moved the tube back to the sulcus, tunneled it a little bit, gave her some space. Also, the conj was super fibrotic, so it wasn't that fun. But, it is one of those things not everyone thinks about necessarily looking under that upper lid to see what's there, or once the lens is on, what is it pressing on?
Yeah.
But I think it's also important for us to think about that. If this patient's going back in the lens, I need to try to give whoever's fitting the contact as much space as possible, which can some eyes can be difficult for some eyes.
You didn't get a chance to talk about that patient where you revised their tube, but in revising tubes, I think those things are critical, trying to figure out what the dynamics of why that exposure happened in the first place. I'm one of those people who tends to always put my tube in at 12 o'clock because I think the eyelid drops the lowest at that point, and the likelihood of having that rubbing effect of the lid margin compared to when you come in temporarily, it's a lot less. So I should probably go back and check all my numbers for all these years. But it's very rare that I have a tube exposure. The other thing about it is if I have a patient exposed in their current location and I can't really find a good reason, I always move the tube from its current position. So I will close that sclerostomy and move it off, usually more towards the 12 o'clock position, further out. And, people ask me all the time, how are you able to do that? Why do you have that extra tube to be able to do that? I always leave myself room for when I come back, is what I tell myself. So when I put a tube in primarily, I snake the tube externally way up, like close to the muscles, and then dive down when I reach the 12 o'clock position. So I always have extra tube material because I didn't cut the tube short to be able to change the position. And I don't think they used to have that tube extender. They don't make it anymore. So now all I need to do is, if I did the primary surgery, there's extra, tube there to be able to reposition that tube.
So I will say that is, I think, something I picked up probably from you is same thing. If a patient erodes, to me, that means the tube needs to move. I don't just close up conj or put on a fresh patch and close conj on any revision. I think it is an indication that that tube just needs to be in a different position. The eye mechanically doesn't like where it is. I'll tell you, one of the things I've had problems with is I agree with the 12 o'clock as well. I like a very 12 tube, but since I've been doing more Zens, oftentimes if that fails, you end up with kind of this ischemic thin conch supranasally, and I don't really want to get into that because I've had one or two that kind of ooze for a while afterwards. And so some of those tubes do end up a little bit more. So if they're pseudophakic, I also like the sulcus. I pretty much have shifted to primarily placing in the sulcus if they're pseudophakic these days, for that same reason, just to kind of protect it as much as possible. Because I've had a couple like Shamil where they just disappear, or they just come in and they haven't been seeing anybody, and it's eroded, and just kind of is frustrating when that happens.
And that possible potential to protect the cornea by putting that tube further back in the sulcus space is it's real, and anytime you have the opportunity to do that, because patients pseudophakic, just I will always take that too.
All right. Looks like we're good on questions. So, all right, we'll close up shop. It was great. Oh, actually, no, I'm going to steal you guys. If you guys got 5 minutes, I'm going to ask you about, I got a case like Shamil's. I didn't present it here, but so he is contact lens dependent. He's had graft versus host disease. So he has horrible ocular surface, had low tension glaucoma diagnosis before his leukemia, horrible ocular surface, contact lens dependent. If he doesn't have his contacts in, his corneal surface is awful. So he's on preservative-free max meds, progression slowly over a couple of years. And so we do SLT once, just the mechanical friction of the gonio lens on his eye. His vision dropped like 5 lines for 3 weeks, just because his surface was so beat up and it took it so long to recover. So it lasted, bottom maybe 6 months, 8 months. I said, well, your next step's probably surgery. And he's like, well, I'm not going to heal up well, so let's do a SLT again. So we did another SLT. He lived with the horrible surface for like a month. And that bought him about a year. And then he comes back and his pressure's back into the upper teens when he's been progressing from 12 to 14. And he's now at 18 on max meds. We've gone through the Ropresses, all that other stuff, and it just beats up the surface too much. So we do a micropulse for him. And he has flare in a fibrinous reaction and just, again, takes him and has a dilated pupil. Lasts for about 3 months before his eye quiets down. He takes pilocarpine now to address the pupil, and it does fix the pupil, and he's okay. And that buys him 6 months. And now he's back to 18 again. And he is symptomatically getting worse. So it's the same idea. I mean, I put a lens on and he gets worse. I can't imagine cutting this guy's conj. I actually had him pop over to the university, get a second opinion for like a GAT ECP procedure. They had the same concerns like, hey, do I really want to make a corneal incision in this guy? Is he actually going to heal up if I make a corneal incision? And so what are y'all's thoughts on him in terms of, he hasn't had a vitrectomy, he's pseudophakic. I could put a tube in, but he'd have to get a vitrectomy. And so I'm a little concerned about whether or not his eye can actually handle all that or not.
Just a quick question. Why does he wear a contact lens?
So without, his dry eye is so bad. He is put in preservative-free tier. It is essentially, it's a special order lens for severe dry eye. It essentially is the only thing that protects his ocular surface.
And right now he's on how many different drops?
He is on alpha-GAN P, Cosopt, and we switched him from Zioptan to Lumigan, which he is tolerating okay.
Okay. This guy needs something done for sure. I would be looking for something that will get him off his drops. Um, this is the type of person that I might stick a Zen in.
Ab interno.
I can do ab externo, ab interno. With the ab externo, when I do ab externo, I sweep down the conjunctiva from the fornix so far back that when I release it, I don't even see my incision point, and I can tell where it is because I always mark my Zen. I'd be happy to share a video. I mark the tip of my Zen so I know where my entry point is. But before I go in to the conjunctiva, I sweep the conjunctiva all the way anterior to the limbus, go transconj anteriorly, and then pierce the sclera. So when I release the conjunctiva, I don't even see my entry point because it's way back there. So this is the type of person I may consider that. The goal is to try and get his ocular surface in sort of a healthier state, so to speak. If I can do that, he's already pseudophakic, get the Zen in there with a small, you can use 5FU and inject multiple times in his case if you don't want to go all the way to the mitomycin route. And this is somebody who you may want to consider that's extra supplementing with a Duristor implant that might last a couple of months, just to keep him going if you need that additional IOP reduction. Or he ends up on way less medicine, maybe 1 drop of preservative-free COSUP a day to keep that pressure close to 12, and we can achieve that with a Zen. So you can go ab interno or ab externo, it doesn't matter. I do all my Zens ab externo right now.
Tosin, you don't take down the conj. You
I
do
don't
it all transconj.
Transconj, all transconj.
Okay.
But people get concerned because they pierce the conjunctiva and then, not to, it's that sweeping the conjunctiva down, all the way down to the limbus, as far as you can with a WEX cell. And then you just go transconj, because then the conjunctiva, when it retracts back into position, it's so far back, it's in the fornix. So infraduct the globe and then go transconj, position, your bleb's forming, and your entry point is so far back that I don't even have to put a stitch in it.
I'd like to see that. I'm still a ab interno or take the conj down person. The transconj, I had a couple, what you just described. I got nice videos of me buttonholing where I have a nice Zen that is in the eye under the conj, but also out of the eye at the same time. So I got a couple patients where it deployed early, right? And you left with a Zen just sitting there underneath the conj. So they have two conj that right next to each other. So yeah, I like the idea of it. I just haven't had as much success as the ab interno, or I like taking down the conj too as well. What are you doing, Shamil?
I've only taken down the conj because I've always felt like the aqueous, I need to kind of get that dissection and get that space. But, I've seen the transconj effectiveness and I really want to try it. So I'm going to watch your video so that I can try it soon, because that's such a much less invasive technique than what I'm currently doing. It's basically a glorified trab the way I do it. I mean, it's much better than a trab, but it's not as minimally invasive as your technique is.
And the added advantage is if you want to needle it, you can right there. Another reason why I sort of mark my incision is because I tried to do my mitomycin C through it. If I had to needle a bleb, I would do the same thing. Just bring that conjunctiva, go with my needle and needle around to make sure I'm easily flexible on all sides, do the mitomycin C, and then we're done. I usually have a corneal traction suture though. So there's a three, the actions of doing this, and I will send you, there was a paper that was published that has that video attached to it. It's a 3-step movement with your corneal traction suture. You infraduct towards the patient's feet when you first start. So you have that great exposure, and then you use that WEX cell to sweep the conjunctiva inferiorly. You then mark your Zen, go transconj. You would have marked 2 millimeters from the limbus. So when you get to the point where you're ready to pierce the sclera, You then, from that inferior location, you pull upwards towards the head, this time to give yourself counter traction, pierce the sclera, right? Once you're in there, you see your needle tip and that hop just stops your position. And then you go ahead and you start to release the Zen. And then the third motion, so you don't get a flick, is as you're coming out. So once half is deployed and you start to come out, you start to depress down towards the floor with superior towards the ceiling traction of your traction suture, so that when you come, you kind of slide out of the eye without that upward flick that most people have, and you just release the Zen, reposition, and you're done.
Well, that is, I can also show you a nice video of a flick fracturing a Zen. So I have one of those as well, of a nice blood forming where there is a Zen shaved off right at the sclera. So yeah, that I'll look forward to that video. I think that'll be helpful. Okay. Awesome. All right, guys. Thank you. I'm on kick all these freeloaders out. I see Todd Mouse is hanging out. He's one of the other glaucoma docs in town. He's a good guy. We're going to shut it down here for the day. Thanks again for everyone attending. Thanks again, Dr. Smith. Thanks again, Shamil. Awesome to see everybody. And we'll see y'all hopefully next month.
Bye.